Good evening, dear webinar participants. Welcome to my webinar titled CAD/CAM Technology for Major Grafting Cases, Reconstruction of the alveolar ridge in the vertical and/or horizontal dimension with a new technology, Customized Bone Regeneration, CBR. I would like to introduce shortly myself. I have been an oral surgeon for more than 27 years. After my education at the University Hospital in Tübingen and scientific work in Germany and the US, I founded 2 clinics for oral and maxillofacial surgery in 1998. One focus of my daily work is reconstructing the alveolar ridge in all its dimensions. The technique that I present to you is designed to make everyday life easier. Have fun with my webinar, and I'm looking forward to your questions after the webinar. Warm regards from Stuttgart in Germany. Do you still know this device? That was my first mobile phone. Over the time, the mobile phone has developed step by step, getting more features, becoming thinner, and today, a smartphone of the current generation looks like that. You can communicate by phone, surf in the internet, writing emails, and useful apps are making your life a lot easier. Exactly the same change has taken augmentation technique in oral surgery and implant dentistry. I will present to you the latest smartphone in augmentation surgery. Good evening to everybody and welcome to the webinar CAD/CAM Technology for Major Grafting Cases, Reconstruction of the Alveolar Ridge in the Vertical and Horizontal Dimension with a new technology, Customized Bone Regeneration, CBR. I would like to present you my idea of grafting, and of course I never forget my wonderful 50 team members. Without them it would be impossible to develop things which I will present to you now. Having worked 27 years literally with a patient to the bone and being orphaned by the augmentation procedures, really exhausted, I thought there must be a simpler solution. After I had successfully applied the method which I'm going to talk about, I decided by founding the company Yxoss to make it easily accessible for all dentists and surgeons. Today I'm speaking to you as a clinician with almost 27 years of experience in bone grafting, and I believe that we found a reasonable solution to make our life a lot easier. This is the agenda I would like to go through with you. First, I will give you an introduction into the customized bone regeneration technique, CBR. Then I will show you the best incision techniques for CBR, followed by a new part which shows the integration of the backward planning principle into the lattice. And finally, I will give you a conclusion and a take-home message. I come now to my first point of the agenda, introduction into the customized bone regeneration technique. For the beginning, I show you a clinical case where we use modern digital technologies to facilitate today's surgical techniques. This is a 66-year-old female patient. She was sent by her dentist to our clinic with the question, are we able to place implants and to avoid a removable prosthesis after the loss of 2 bridges in the posterior part of the mandible? As you can see, this resulted in a severe resorption on both sides, and you don't need an X-ray to estimate the low amount of bone which will be available for placing implants. You can see it here on the left and on the right side. The analysis of the CBCT scan showed up that the alveolar ridge is sharp like a knife edge. The vertical dimension was not too bad, but there's missing bone on the lingual aspect as well on the buccal aspect, as seen here. And we were also facing combined defects, as you can see here on the lower picture left. What could be now the right technique, or in other words, what are the treatment options to rebuild the bone on both aspects if you want to rebuild the ridge properly? Today we have many errors in our augmentation box, as they can be seen on the slide, starting from bone spreading, bone splitting, all the block techniques customized or harvested from the same individual, the old mesh techniques, and so on. I'm convinced that everybody of you recognizes techniques which you are performing in your own dental clinic. I want to show you how we rebuild the ridge in this case. In the first step, we created a virtual 3D model which is based on the patient's DICOM data. These data, DICOM files, are exported from CT scan or CBCT scan. Then, as seen in the middle, we draft the desired bone volume, and based on that, we design a lattice which covers the augmentation volume. In a 3D printing process, the virtual design is transferred into this lattice structure, which you can see on the picture on the upper left, on the lower left, like this here. The fabrication of the lattice is done by a 3D printing job called selective laser melting. Metal powder is put layer by layer on the building platform, where it is computer-assisted melting using a laser. So, and the lattice is built downwards from the building platform, so you can't see it right now. And when you remove the building platform, it looks like this here. On this picture, you can see the final product after finishing the print job. The first important question to be answered is, in which biological composition do we fill the lattice? Well documented in the literature is a mixture of 50 to 50, that means 50% of autogenous bone and mixed with a bone substitute, for example, like you can see here with Bio-Oss. Yxoss is able to assist in the planning of your grafting procedure by calculating the necessary augmentation volume. Using the knowledge of the volume of a cylinder, it is pure math to calculate the volumes needed if you use a hollow tree-fine drill. You obtain the data together with a 3D design proposal made by the design center. The volume is given in cubic millimeters and follows the formula above. On the website, you can do the calculation on your own. The augmentation volume in the first line here, in this case it's 850 cubic millimeters, and you will be provided by the engineer with that number. In the second line, you fill in the inner diameter of your hollow tree-fine drill here. And last but not least, you add the percentage of your autogenous bone material. Finally, you click calculate and you will get the result, how deep you have to insert your tree-fine drill to get the desired volume of autogenous bone. This calculation allows you a minimal invasive surgery. In this case, 50% of 850 cubic millimeters is 425 cubic millimeters. If you want to harvest this amount of autogenous bone, you have to drill 15 millimeters of depth with your 6 millimeter hollow tree-fine drill. It is also necessary to clarify how the augmentation volume is designed. Do we remain in the skeletal envelope, or, as has so far often been required due to the resorption processes of bone blocks, we wish to over-augment? We are designing at the moment as far as possible in the skeletal envelope, since we have a good experience with it, and over-augmenting can always cause a problem of plastic cover. Back to our case. Now we start with the surgical part, and we will take the time, so we start here with 0 for the surgical procedure. In this case, I recommend a surgical access via a split thickness flap. The mucosa is incised about 12 millimeters apically from the mucogingival junction. Then you prepare the mucosa flap up to the mucogingival junction, and in a next step you incise the periosteum sharply and elevate from this point a mucoperiosteal flap, which is mobilized to the lingual aspect. This will be part of the exercises when you are visiting a workshop. Then, according to our volume calculation, we harvested as many bone blocks as needed, ground them in a bone mill and mixed it with Bio-Oss. And as you can see here, you get after you crown the bone, you get lovely bone curls or butter curls, and they are very, very workable. The shell is loaded with the grafting material, placed onto the bone and fixed with screws. Due to the precision of the shell, fixation with 1 or 2 screws is sufficient. Here, you see it's 2 screws. Out of my personal clinical experience of more than 190 cases, to cover the lattice structure with a collagen membrane still seems to be beneficial. After stress-free suturing, the following healing period of 5 months, starting from post-op till 5 months later, has been documented. As you can see here on the pictures, it shows all over a very good healing. And as you can see, for one side, we stopped the time. It was 40 minutes. Grafting procedure for one side. 5 months later, a CBCT control has been conducted. It shows a very good regeneration of the bone on both sides, and we were able to develop the alveolar ridge into the right direction as we planned before. Here, as you can see here, to the lingual aspect as well to the buccal aspect, and same on the other side. And also in different directions. Yeah. So in 4-6 it was only to the buccal aspect, and in 4-5 it was on the lingual and buccal and in the vertical to the vertical aspect. To minimize the surgical trauma through the re-entry, it is favorable to position the fixation screw next to the crest and so to allow a minimized flap. You may have realized that in the design you can recognize a gap that divides the lattice structure into parts. Then, here, you can see it here, it's the gap in between. The screws are removed by applying rotating forces with a periosteal elevator in between the two mesh parts. This enables us to remove it in 2 parts, as you can see here on the right side. That is just what, well, these are the 2 parts which remain later. And you can see the nicely regenerated ridge, and this is real vital bone. You can see here the bone. We are often asked about the removal of the lattice. Here you can see a short video of the removal from another case. I removed it in 5 minutes and show you a short sequence, in particular the splitting of the lattice structure. So it's very easy to divide it into 2 parts. To place the implants in such a nice ridge is pretty easy, and so it was possible to place the implants in the ideal position, and in region 4-5 and 4-6 we took a bone cylinder to give it to a histological examination, and the histological examination documents a very nice bone regeneration all over, as we have been confirmed by Professor Hemmerle from the University of Zurich in Switzerland. To conclude this case, the postoperative X-ray and the final prosthodontic restoration, please have a look to the relationship between the jaw and the clinical crowns. This allows good oral hygiene. Based on that, a good long-term result is expected. And in the meantime, we have a 2-year follow-up. In addition, we can now show you a 2-year follow-up with a very stable bone and soft tissue situation. Especially here, have a look, looks really pretty nice, the bone level, and everything seems to be stable. Kalmish expressed that the goals of a peri-implant prosthetic rehabilitation is to restore the patient to normal contour, function, comfort, aesthetics, speech and health, regardless of the atrophy, disease or injury of the stomatognatic system. In order to achieve this goal, today's implantology is not mentionable without a correct and strict hard and soft tissue management. Today, implants are placed in the ideal prosthodontic position, which means that we must focus on the planned surgical site. Then, if necessary, bone augmentations may be applied to enable the desired prosthodontic treatment goal. So, according to Boozer and Lang, as seen above, augmentation procedures need to be performed in lots of cases. All over, Boozer says it's about 40%, and if you are going, according to Lang, into the aesthetic zone, we have in 90% of the implant placement, additional bone grafting is required. In one of the latest papers, which was published last year in 2017, out of 67 centers with around about 141,000 placed implants, in 42% additional bone augmentation was required. This confirmed again the data of Boozer and Lang. Biological success factors for bony augmentation are form and volume stability, physiological load, growth factors for vascularization. I want to focus on the form and volume stability. Based on the literature, the most successful and the most applied technology is the GBR technique, where more and more resorbable membranes of collagen material are widely used. However, there are some challenges which have not been solved perfectly. Mainly these are the limitations in membrane stability, to maintain the augmentation volume, then membrane fixation to keep the membrane in place could be quite difficult. And of course, micro movements which disturb the uneventful healing. The influence of the stabilization was shown again beautifully by Miamari from Barcelona in 2015. In vitro, L-shaped defects were placed in a porcine jaw and implant placed and the augmented horizontally in 3 different variants. First one was only with Bio-Oss and just covering it with a membrane. The second was Bio-Oss covering it with a membrane, but with a fixation, the membrane has been fixed with the titanium pins. And the third variant was just to use a Xenogene block and to cover it with a collagen membrane. And CBCT has been scan was performed before and after wound closure. The results show that obviously only the soft tissue pressure that develops after wound closure can already lead to a significant volume loss. That means, as you can see here, with the variant 1, you lose about 50% of your grafting volume. If you already use pins, you're about 20%, and of course the Xenogene block is the best with a less than 20%, because the grafting material flows away. Istvan Urban has shown with his sausage technique that it is easily possible to achieve good results for horizontal augmentation. In the vertical dimension, this technique has considerable limitations. In addition, the application of the pins, and particularly lingually, is very difficult and easily feasible only for the experienced dentist or surgeon. To be honest, in my hands, it doesn't work well. But because he got nice results with his technique, he has a horizontal gain of about 5.7 millimeters, and with a 100% implant survival rate. This is a clinical case from my clinic from 2005, and the GBR technique has been applied. The grafting was a mixture of autogenous bone and a xenograft, and covered with a collagen membrane. And it looked nice after the wound healing, was no problem. But if you have a look in the follow-up of this patient, starting from the prosthodontic treatment till 2012, we faced some long-term problems. As we all know, soft tissue follows hard tissue, and insufficient bone volume results in progressive bone resorption and consecutively in loss of soft tissue. And you see, after 6 years, there was a stabilization on a lower level, and I'm quite happy that the patient has the lip line is not too high in her case. The problem, we were not able to create a 3D stable submembranous volume. So we didn't regenerate enough bone or bone volume, and due to some instability of the grafting material during the healing period. To guarantee the stabilization, many techniques have been recommended, such as, for example, the titanium reinforced Gore-Tex membrane. These are all cases from my clinic. And so we really, I think, performed all the techniques already which are in the market or which are well known. The tenting technique, bone splitting, shell technique according to Professor Curie, the old mesh technique, then sonic weld, bone blocks, and of course also the distraction osteogenesis. All have been more or less successful, but for all there are remaining some individual drawbacks, and they do not really simplify the surgery. A review of the brothers Strelch has analyzed the literature in a time period of more than 20 years, from 1995 to 2015, and the clinical efficiency of grafting materials in the alveolar ridge. So the examined defect types have been dehiscence, or the included defect types in the study have been dehiscence defects, fenestration defects, horizontal defects, and vertical defects. Not included have been defects like the sinus floor elevation, periodontal defects, peri-implantitis defects, then extraoral harvested bone, and soft tissue augmentation. Included have been 184 studies, that is just a quite big number, and with 6,182 patients. With particulated graft or with particulated material, the benchmark is about 4 millimeters, as you can see here, using a collagen membrane. The red bar is for the vertical gain and the blue bar is for the horizontal gain. In the review, this can only be overcome if one works stabilizing, for example, with an old titanium mesh, as you can see here on the lower left, a picture from a publication from Rocuzzo, where he is stabilizing the graft using a titanium mesh. You can see that very nicely on the chart. This gain is achieved both on the vertical and on the horizontal, as you can see, but at the expense of the complication rate that increased slightly, and that is seen on the yellow bar. The motivation to think about a solution for the remaining problems with which we are still confronted were challenges like that curves are not possible to be rebuilt properly, and individual anatomical shaping is difficult. Here, for example, as you can see, it was a grafting with bone blocks from the iliac crest, and you see that a curve is quite difficult to be rebuilt. Then incomprehensible resorptions. Have a look to the two screws. They are about 7 to 8 millimeters to each other. One is almost covered by bone here, and the other one, there is resorption up to 50% of the screw length. Then we have no 3D stable regeneration volume. We have a missing preciseness of the volume, and of course, out of the knowledge that regenerated bone has biologically the highest quality or value. And last but not least, The surgery should become easier for the patient, of course, but also for me as a clinician. I come to the second point of my presentation. As we all know, one of the key factors of a grafting procedure is the right surgical technique, and as a part of it, the right surgical access. I would like to show you from my experience which incision technique to which defect fit best. The incision technique follows the geometry of the bone defect. Out of my experience, we recommend to use in horizontal defects, you can use a crestal incision. Same for vertical defects, up to 2 millimeters, which is in the second line. In all other defects, that means more than 2 millimeters in the vertical dimension, and in combined defect, we prefer the poncho technique in the upper jaw and the split flap technique in the mandible. To all techniques, you will find on the Yxoss webpage a video. It's not possible to present it in this webinar, but it's easily accessible on the website. News also that we are able now to integrate into the lattice a planning for the implants. The backward planning principle, which dates back to Garber and Salama, was first published in 1994. In other words, it could also be called forward thinking. The question that needs to be answered is, how do we come in a predictable way from the situation in the upper left here to the situation in the lower left, or as you can see on the X-rays, from here to here. What is backward planning? Backward planning is a comprehensive concept for implant planning and restoration. It starts from the desired end result and plans the work steps from there on backwards. First, an anatomical temporary denture, mock-up or similar, is made. This is used for functional and aesthetic fitting. On the basis of this, the information obtained, the ideal position on the dental implant can then be determined, and all necessary measures, also in the augmentative area, hard and soft tissue, are carried out in order to achieve the desired goal. Basically, based on the versatile software that is available today, it is easily to implement an implant planning via a pure digital workflow. As shown here, a digital mock-up can be created. Then the implants are optimally positioned and the necessary augmentation volumes are created according to biological aspects. As I already mentioned, we are now able to incorporate implant planning into the lattice. A virtual mock-up is done, as you can see here on the slides. Then the design of the augmentation volume is according to biological aspects which are scientifically proven. And the lower edge of the round neckline reflects the position of the implant shoulder. The fit for the planned implant is that the ring is 0.5 millimeter bigger as the planned implant diameter. That allows you to place the implant through the hole into the jaw. The implant position is in a sense of an orientation template or a bone supported template. One-step and two-step approach is possible, and the decision is to be done by the doctor and of course by his clinical experience and dependent on the case. I now come to the last point of my webinar. I finally give you a conclusion and a take-home message. This is the basic publication in the journal of oral implantology with a case from 2012, where we successfully applied the technology the first time, describing the workflow. So yeah, the workflow and the technique is very precisely described. And if you like, you can send me an email and I can provide you with a original publication as a PDF. So let's make a definition of the customized bone regeneration technique. It's a technique that, as a further development of the well-proven guided bone regeneration GBR technique, not only creates a compartmentation, just membrane-supported separation with a collagen membrane or another membrane of soft tissue and bone, but also offers the 3D stability of the desired augmentation volume. Due to the digital workflow based on the patient's DICOM data, is it possible to design and to develop the alveolar ridge in the desired direction according to the backward planning principle. You also could say it's a prosthetically guided regeneration. A study from a Japanese working group showed up that there is a significant reduction of the surgery time and from the number of screws which have to be applied for the fixation of a medical device. It saves only, as shown here, not only time, you also need less screws. Here, it's here in average 75, and before it was about 111. I will show you our numbers later. We save a little bit more time in the meantime, and of course you only need about a third or maybe 40% of the screws compared to other techniques. What are the indications of the CBR technique? Primarily overall where one has non-self-contained defects. Self-contained would be, for example, as seen here, class 1, according to Ter Heiden, a sinus floor, which is like a bathtub, or the intact socket where four walls are still existing. Following the classification, the transitions of class 2 to 4 are fluent. The technique could be particularly beneficial in the class 4 range, but it is also possible to exploit the advantages of class 2 and 3 defects as shown in the picture to the right. There it was used here to only to recontour the ridge in order to get a perfect aesthetic outcome. To conclude this webinar, we have a full digital workflow, profound 3D stability and predefined augmentation volume according to the backward planning by the technology. The fitting is more precise than it is really clinically required. It's up to 0.1 millimeters. You really need less fixation screws. We have a significantly shorter surgery time. It's up to 60%. The regeneration of complex bone defects is possible. It's easy to place and easy to remove by the easy removal design, and of course the 3D stability which is offered by the technology could close a very important gap in GBR. Thank you very much. and have a nice evening.
Yes. Hello. I hope you enjoyed the presentation, and if you like now, you can ask your questions. I got one question. One user asked, which bone mill do you use? The bone mill we use is the bone mill from the company Mondial. A second participant asked, what do you think of Max Resort? I know the product, but I don't really have experience with it. The third question was, what protocol of antibiotics do you give? In general, our first choice is amoxicillin for patients who are not allergic to it, and we prescribe for 5 days 2 grams per day. Then question number 4 is, what website are these flap techniques available on? The flap techniques, you can see them on www.yxoss.eu. Then you go to clinical use, and there you will find it under Yxoss CBR OP videos. The next question is, what are the exposure rates of the membrane? That is a question from Mark. Just when we analyzed our first 100 cases, we had an exposure rate of about 20%, which is comparable to all other grafting techniques. Now we just analyzed our second 100 cases, and we realized that the exposure rate is significantly decreasing. The reason for that is that we had a learning curve, and that we changed our incision techniques. So now, just when we have a look to our data, we think that it's less than 10%. So it's just the next question: protocol of antibiotics and anti-inflammatory. I think that I just answered that question. The same, please. Can you provide the link for the bone mill? Sorry, didn't hear what you said. Okay, the bone mill is Mondial. The company name is Mondial, M-O-N-D-E-A-L, and the name is Bull Mill. Why is the technique better than using customized blocks from produced by Straumann? Okay, the next question is, why is this technique better than using customized block produced by Straumann? I think that crafting with particulated material offers a lot of advantages. So if you have a dehiscence, for example, and we made a review of the whole literature concerning dehiscences, bone blocks, allo bone blocks, like the bone builder, for example, when they have a dehiscence, it is really, so then it will result in a total loss of your grafting volume. And this is, if you use the CBR technique, you only will have a partial loss of your grafting volume. The next question is, do you use a combination of autologic bone and Bio-Oss. Yes, according to the literature, we follow the protocol, and that is very well documented. 50% of autogenous bone and 50% of Bio-Oss. There we have real good data. Another user is asking again for the website again. So the website is www.reoss.eu. Reoss is R-E-O-S-S. And there you go. Just must have a look to it. You will find it. You go to clinical news, and there you will find under Yxoss CBR videos. What about if the membrane titanium is exposed? What is the rate of failure of the graft as a whole? That really depends on the size of the dehiscence. But our experience is that if it's only a very small dehiscence, you will lose a little of your grafting volume. If it's a bigger one, then it could be up to 50% of your grafting volume. Do you have a training course on this technique is another question. Yes, we do have. We just had one today. So in the next in 2019, we will have 3 courses, 2 days in Filderstadt here, which is next to Stuttgart Airport. It's a 2-day training, and the dates you can get from Geistlich UK or from your distributor in the Netherlands. Another user is asking what are the costs of the Yxoss mesh. That depends on the size of the lattice. It starts for a single tooth. It starts at 295 euros, and a whole full arch is, I think, 750 or almost 800 euros. Do you have any more questions? So thank you very much for attending my webinar, and have a nice evening. Yeah, warm regards from Stuttgart, and good night.